Hello, Reverend Spearman, you on mute.
Hey, Miss Kanisha, how you doing, sweetheart?
I'm doing well. I'm doing well. Good to see your lovely face.
Yours as well. That's the first time I ever heard it called that.
And Dr. Laws, you should be in as well. Hello, Dr. Murphy.
Hello. I am.
Hello. How are y'all doing?
Doctors Murphy and Dowdy.
Yes. What up,
everybody?
Wonderful.
Hi.
Good to see you all.
So, Dr. Laws, just to let you know, we cannot see your face.
That may be intentional.
It could be. And you're on mute, Dr. Laws, if you're saying anything.
There he is, Big DW.
Hey, Davon, sorry I was blowing you up, but I couldn't let people in for whatever reason initially. You're on mute, Davon.
You're on mute.
Oh, it's fine. I'm on two Zooms at the same time. In this one, but I do apologize. So I'm glad that everything worked out and everybody is here and all is well.
We see you, Dr. Laws.
Hey, Dr. Laws.
Hello, everyone. Hey, Reverend Spearman.
Hey, Dr. Laws.
Murphy. Hello. Hey. Yes. Good to see y'all.
Yes.
Good to see you as well.
Do you
Just
all know
laughing
each
at
other?
Who?
Do you all know each other? Does everyone know each other? Okay, perfect. Okay, so we don't have to do introductions or anything like that with the group.
We're brothers and sisters of the Lord.
That's right.
Praise his name.
Do y'all have any questions with regards to the script or the flow or anything like that?
I don't, but I'm going to go grab a bottle of water.
Okay.
I'm going to hop off one minute.
That's fine. And we're just waiting on Dr. Akinboyo to join us.
Okay. I'm not sure that I reviewed the script. I think I might have. I don't remember.
It's pretty straightforward, Dr. Spearman, and Dr. Dowdy is going to be running the show, so he will let you all know when it's time for you all to be speaking and not speaking. But you're part of the panelists, so Dr. Dowdy is going to welcome everyone to the meeting. He's going to just give a quick overview of who Hill is, and then he's going to go ask people to respond to the poll that we're going to have active. And then he will transfer to Dr. Murphy, who's going to share his personal story, his personal testimony. Then after that, Dr. Akinboyo is going to give her presentation. And then we'll maybe have a couple of questions regarding her presentation, and then we will roll into the 2 questions and overall discussion.
All right.
And I'm just trying to see. Right now, we just have 4 people waiting to get in. There's Dr. Sister. Hi, Daphne.
Hello.
Hey, Daphne.
Hello.
Daphne.
Hello.
Oh, they want to say.
Here, I'll turn this on.
And so just to let you all know, once we get into actual presentation, we're going to pin the person who's speaking at that time. Like when Dr. Dowdy's speaking in the beginning, we're just going to have him on the screen. And then the same for Dr. Murphy and Dr. Akinboyo. We're just going to have her on the screen. And then when we have the panel discussion, we'll have all of you all on the screen.
Okay.
And looks like Dr. Christine is on now.
Yep.
Yeah, I'm sorry for the back-to-back scheduling here.
No problem. Dr. Christine, do you mind pronouncing your last name?
I do not mind. Its last name is Akinboyo.
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 And first name Ibukun.
Ibukun. Okay. Ibukun Akinboyo. All right.
Akinboyo.
Are you good, Dr. Dowdy?
I'm good.
Dr. Akinboyo, do you want to just quickly give a quick introduction of yourself to the panelists?
Yes, I can. Let me make sure my camera is working here. There we go.
We see you.
Okay. So I'm a physician at Duke. I trained in infectious disease, and I've been working with the Mayor's Recovery and Renewal Task Force, and that has been most of my community work around COVID-19 in the past year. So I can do more, but I think that's what you were asking about.
Yes. And so everyone, it's 6:31 now. We will begin to start letting people into the room. Did any of you all have any questions though before we do in regards to the flow of today's webinar, or tonight's webinar?
Do you want all of us to mute until we're?
Yes, please. That will definitely help with the background noise. And Dr. Dowdy, I will be chatting and texting you questions as they come about. And so you can direct it to the panelists as needed.
Will I be able to share my screen? Can I?
Yeah. Oh, yes. Let's go ahead and make you a co-host right now.
Thank you.
Davon, you're going to have to do that.
Okay, here we go.
And then also, Dr. Murphy doesn't have any slides, correct, Dr. Murphy? Okay.
That's correct.
Okay. Are we good to start letting people in?
You can open the door.
Yeah.
All right.
And Dr. Dowdy, just let me know when you're ready for the survey, the pre-survey to be sent out, and then I'll send that.
Davon, I was talking to Dr. Dowdy just a few minutes, and we were saying when he gets to the part where he's going through the slides about the about HEAL, maybe we can just go ahead on and release the survey then, and then he will prompt them after he's done to say, please respond to the survey questions. Is that okay?
All right, perfect. Yeah, that's perfect. Thank you.
All right, I'm here. Please text if needed. I'm going to go off camera, but we'll be working in the background. Thank you all for your time.
Okay, I would like to thank everyone for joining us tonight for this second presentation of this webinar that we're doing on COVID-19. My name is Dr. Orlando Dowdy. I'm a pastor in the AME Zion Church, as well as a psychotherapist in private practice, and part of the HEAL partnership. And I believe we've been meeting somewhere around, I think February this month, made 5 years for those of us who were here in the beginning. And this webinar is brought to you by the AME Zion Health Equity Advocates and Liaisons HEAL Partnership in collaboration with the Community Engagement Research Initiative, commonly known as CERI, along with the Duke Clinical Translational Science Institute, or CTSI. And this is a picture of some of us, not all of us, that you may see here, that's also on a postcard that we pass out. And we exist to foster health equity and improve health in the African-American community through a partnership designed to build trust and collaboration in order to address disparities and increase engagement in clinical research. One of the things we also deal with is dispelling myths and negative perceptions of clinical trials among people of color. And that's due to some of the things that have happened in history. So we have to cultivate trust. And that has been one of the primary concerns for us, is to cultivate trust. And each one of us, we've all had to deal with this in the very beginning. We all had questions. And so we had to deal with those myths and our very own concerns for safety for people of color. And so we've done that. And so we want to bridge the gap between medical development and community needs as well. And this webinar is a platform for hearing and learning about issues that are important to our community. Today's webinar will address the current realities of COVID-19 in the Black faith community. And as I've already stated, we've done one webinar, and this is our second. And now you see some pre-survey questions on the screen. And now I would like for you to go ahead and please respond to these live poll questions. First one is, have you received the COVID-19 vaccine? Question number 2, have you tried to get the vaccine but was not able to? And question number 3, if yes, what prevented you from receiving the vaccine? And there's some questions, some answers there: fear, transportation. I'm not sure, Davon, are there any other answers, or those are the only 2 for number 3? It appears those are the only 2. So if you will take the time to answer those now, please. Give you about another minute to answer those. We'd like to try to capture all of you who are answering the pre-survey. All right, thank you for answering the pre-survey. Appreciate you taking the time to do that. That will be helpful to us and hopefully helpful to you. And so at this time, you can see pictures of our panelists. I'm not quite sure, someone snagged that picture of me. I'm on the left, and our next speaker is the Reverend Dr. Paul Murphy, Paul G. Murphy, G standing for green. But prior to his speaking, let's look at the poll results. We can see 60% says no, they have not received the vaccine, but 40% yes. Number 2, 87% says they were not able to get the vaccine, and 13% says they have been able to get the vaccine. They tried. Yeah. And number 3, of yes, what prevented you from receiving the vaccine? Only 7% said transportation, and 0% said fear, which is quite interesting for those that have gathered for this webinar. Thank you. If you have any questions, by the way, please put them in the chat. I see someone said he could not submit, but the poll has ended. But if you have any questions, also please put them in the chat, and Miss Kanisha Bethay, excuse me, she will take those up and she will compile them, and I will try to get those addressed as well. Now we have Reverend Paul Murphy, Reverend Dr. Paul Murphy. He's one of my dear friends, childhood friends. And so he and his wife, and I think 2 of his children, both came down with COVID-19. And so he will tell us about his experience with this virus. So Paul Murphy.
Thank you, Dr. Dowdy, and all who are attending. As Dr. Dowdy stated, he and I have been friends since way back in grade school. But we've also been able to be on the ministry journey together. And part of that ministry has been work with the Hill Partnership from the beginning, and serving our home church right here in Southern Pines, Trinity Amy Zion Church. Once the onset of the pandemic became a reality in our community, we automatically went into a posture of worship service outside. To drive up, cars would pull up into the parking lot. I would stand outside on the top of the stairwell and preach. And almost immediately, the posture of the church moved into one of generosity. We heard that there were some mask shortages at the First Health local hospital. And some of our dear members, one of whom is on here with us tonight, got together and began to just make masks, just sewing. And this was long before there was really the mandate for the mask wearing. So I'm proud to be a part of such a caring church. However, back on October 25th, I was standing out there. It started to rain. My loving mother, who's a member of the church, was questioning why I didn't have an umbrella. And I said, well, Mama, I was just moving in the spirit, preaching, and I'll be fine. 2 days later, I came down with something that I figured was just a cold from being hard-headed and not listening to my mother. My son out in Los Angeles, however, being inundated by all of the tragic COVID issues out there, called and said, Dad, you need to go get checked. You know, you might think it's a cold, but it might be something more. So my wife, Sharon, and I went over to be checked. And of course, we both were diagnosed with COVID-19. Pretty much a shock, a psychological shock to hear that so early. That was on October 30th. Sharon's issues seemed to me to have been worse than mine. I basically had the fever, the chills, the nausea, and the diarrhea. But in addition to that, Sharon lost sense of taste, sense of smell, and had the repetitive cough syndrome. So when we went out to the hospital to really say, okay, that things aren't going that well, they checked us both out. And of course, I still had my sense of taste, sense of smell, and we got ready to go. They let her go, but they kept me. And I was like, why are you keeping me? Well, it turns out that while Sharon had these symptoms, I was really not receiving the oxygen necessary for my organs to really function. It was a pretty serious thing, and I had no idea. I felt like I was breathing fine and that I didn't have all the coughing stuff. So they kept me and they had me on oxygen pretty much all night. And fortunately, the following day, the oxygen levels were fine enough for me to be discharged. And then once getting home, I had a great appetite. I figured I could, eat as much as I wanted. I still had the taste, as I mentioned. But after one particular meal, I went into this mode of hiccups. That was the strangest thing. That was the most awkward thing, because the hiccups they were kind of involuntary, on steroids, so to speak. I could not stop. I tried to hold my breath. I tried to drink water. Nothing helped. And for 3 days, I could not sleep. The hiccups were there. I went back to the hospital to find out that the oxygen level had dropped again. And the body was just heaving, going into that mode, I guess, of just trying to get oxygen at whatever cost. And that's when the reality of COVID-19 really hit home, when I realized that this particular disease can kill. I felt it. I felt it physiologically, emotionally, psychologically, every level. I began to think about what things I needed to get done, what things I'd left undone, all of those kinds of things that I guess one thinks about when you're on the journey out of this world. And right in the midst of all of that particular struggle, I received a phone call that a young man who was a dear friend, all of my children had died, and his parents wanted me to do the service. And I don't think they realized that I was actually under the kind of the COVID journey myself. But that following day, in the midst of the intensity of the hiccups, in the midst of the vomiting and the diarrhea, the fluctuations in temperature, fevers and chills, God spoke to me about that young man's funeral. And since the young man was a songwriter, wonderful songwriter, wonderful artist, the Lord simply said, create. And as soon as I heard God say create, in dealing with the eulogy that I need to create, everything went away. All the symptoms went away. The hiccups stopped right on, at the drop of a dime. The temperature issues, everything was just almost back to normal. In fact, I felt so great that I went out that afternoon and figured maybe since God has healed me, I can play some tennis. Opened up a can of new tennis balls, was so excited, grabbed the racket, and the first ball I hit felt like hitting a brick. And while I really do believe God had kind of started me in the healing process in somewhat of a miraculous way, I think he also had to help me to realize that I needed to operate with common sense and get the rest that was required. And of course, the real part of the journey was coming to the place to realize that not only was I blessed tremendously by having this healing to happen in my body, when I realized that my wife could have died, that 3 of my children who also contracted the disease could have died, and yet all of us are here and yet alive in the midst of the incredible numbers who have died. I am grateful to God, thankful to all of you, certainly thankful to HEAL, to the researchers right here at Duke, and all that has gone forth that's creating the miracle for others throughout the world right now to receive the vaccination, for people to continue to wear the mask, to protect themselves, because this is definitely something that you would not want to experience. Thank you so very much.
Thank you, Dr. Murphy, for that witness and that testimony. Certainly we have, we're witnesses to that, because many of us have had family members or friends to contract. Some of us who are here tonight participating have also had the illness. I have not, but I know of some others who have. And so certainly we thank you for that and reminding us of how deadly it can be. And even for those who live, how challenging it can be just to be able to breathe and to be able to move about. Now, and I see that some are sharing their thanks to you for sharing the story as well in the chat. Now, we also will hear now, we have a presentation, and I want to make sure that I pronounce her name correctly. And if I don't, please, Dr. Let's see, it's Akinboyo, but I believe it's Ibukun Christine Akinboyo. And she is Assistant Professor of Pediatrics, Infectious Diseases at Duke University School of Medicine. And so now we shall hear her presentation and hear her. Thank you for being with us.
Thank you, Dr. Dowdy, and you pronounced that quite well. And also thank you, Dr. Murphy. I think I certainly sit in science, and my goal today is to talk from just share the science around in COVID-19 and vaccines. But I think what's more powerful, and let me just make sure some of my technology is working as intended. Can you see my screen? Yes, I got one nod. Okay. So I think what's a lot more powerful is really focusing on the experiences around COVID-19. That really tells the story, and that helps to center us on the conversation on vaccination, and why we should talk about vaccines, and certainly be eagerly looking forward to some exit strategy out of what we've been going through for the last year. So I only have a couple of slides. I know we have a lot of time for questions. I doubt I can address every single question that's out there regarding vaccines, but my goal is to just have a broad overview. Some things you may already know, some things have been in the news already, but I hope it will set the context for some of the questions that may come later. And what I'm here, as well as some of my other colleagues, and we can address questions that may be more specific for your situation. So taking a huge step back, it's important to just mention that the virus that causes COVID-19 is SARS-CoV-2. I know we say a lot just about COVID-19, but the reason the vaccine works is because we now understand the virus a lot better. And that genome right there is the virus. It's quite simple. It doesn't really, in terms of some of the other complicated things we have in our environment, this is probably one of the simpler ones. Has caused a lot of chaos, but still fairly simple. Coronaviruses are not exactly new. They are, this particular virus, this novel coronavirus is new, but coronaviruses have jumped from animals to humans in the past. We didn't pay enough attention to SARS-CoV-1. It wasn't as much of a problem for the United States, but the Middle Eastern countries experience this, Asian countries experience this, and also MERS, or Middle Eastern Respiratory Syndrome. The shape of it is also important. We now know that there's this area, sorry, I'm having a slight delay on my end with the slides. I will try one more time here. Okay. We'll power through, it'll work. All right, so we know that there's that area in brown. It's the genetic area of the virus that codes for spike protein, and the spike protein, and I'm emphasizing this because this is the technology behind the vaccine. So the spike protein is just those tiny little spikes right around the crown. Coronavirus is a crown, tiny little spikes around this. We understand all this. We've sort of gone past the question about how this actually works, or how it's set up. And this allows us to now have questions about or create vaccines. So the other thing we now understand, I think we've established well, that the 3 W's work. Wearing a mask works, waiting distance from people that are infected, and certainly washing our hands. We should have been doing at least the washing of our hands for a while. So this year has shown us that if we wash our hands adequately, we would see even things like influenza kind of disappear from our communities, which I think is great. This was early data from the CDC showed 2 hairstylists that didn't know they had COVID-19, interacted with a ton of clients, but thankfully, none of them got infected, even though they were, just think about going to the hair salon, even though they were pretty close. This context is still important as we talk about variant. Masking works, distancing works. But my goal here is really to talk about immunization and vaccines. You've probably already heard about the 2 vaccines that are being distributed. I'm going to focus on both the Pfizer and the Moderna. I know that as we're having this conversation, there are other vaccine types that are going to be reviewed and are going to be distributed, but hopefully we'll have more sessions to address those. The principle behind vaccines, though, are the same. mRNA technology, mRNA vaccine technology is a little bit new, but not as new as just last year. People have been working on this for decades. The Ebola virus, the Zika virus, all of the prior problems we had around viral spread, people considered mRNA vaccines. Remember the spike area I showed in the last slide? All the vaccine does is give that list of instructions, which is the spike protein, injects it into our muscle, tells our body, here, you should make that spike protein, not the entire virus, just the spike, because all we need to recognize that the virus is a foreign object is if we see that spike. So that's all the mRNA vaccine does. Quite simple, comes in, makes a spike, our body recognizes that spike is a foreign object and we don't need it in our bodies, and it makes antibodies or protective elements to get rid of it. This does not give you COVID-19. I have a slide on symptoms, so I'll talk about some of the vaccine-related symptoms. I think some people have felt like they got COVID-19 post-second dose vaccine, but the vaccine really doesn't give you COVID-19, and it does not interact with our DNA at all. It's sort of use, rinse, repeat, and send it out. I'm not sure why this is doing. So what is in the vaccines? Again, publicly available data, that list of instruction, the mRNA, lipids, so some things you can actually find in your kitchen. We can't make the vaccines ourselves, but what goes into the vaccine are fairly simple things. Lipids to keep the molecules from sticking together, salt, sugar, and buffers to allow us to defrost it. It's stored in the freezer, and then inject it into muscles. There are no preservatives, no embryonic cells, no additives. Again, there's 2 vaccines. As we get more vaccines on the market, we may have to have this conversation again. But the 2 that are being distributed do not have any of these things. Some people like more detailed information. So I have 2 slides just on the actual details, and I can share this with you. I won't belabor the point here, but some people want to know what's the difference between both. Why do we have both on the market? Should I get one versus the other? And the simple answer is you should get the one that's right in front of you. If you have access to Moderna or Pfizer, you should get whichever one you have access to. There are some very subtle differences, but they do not actually make a difference in terms of how it works in our bodies. But for those that are interested, there's a slight difference in I'll make sure I show that. So Pfizer versus Moderna. Slight difference in the amount of spike protein, so the list of instructions. Think of it as one is 10 pages long, the other one's about 100 pages long. But the only reason for that is what I highlighted in red here, which is that we store Pfizer vaccines in sort of the deep freezers, special freezers. Moderna is stored in slightly warmer temperatures, and it may break down a little bit. So to allow room for breakdown, they just added a little bit, they added more pages. So they added some extra mRNA components. Both of them are 2 injections. One is 3 weeks apart, one's 4 weeks apart, just has to do with the clinical trials. And they studied these vaccines in over 70,000 people. Both of them have a high enough efficacy that we know it works, 95, 94%. I will go into the chat and try and answer questions, but if there are any urgent questions or something I should clarify on the slide, please feel free to interrupt and just let me know. Again, the specifics on efficacy, I try not to just show the clinical data. This is what they had publicized. I will highlight a few things. The whole point of having a vaccine trial is to use a placebo or salt water and use a vaccine in clinical trial participants. So what we're distributing at this point is a vaccine. I think someone asked me in one of my prior talks, are people still being picked to get placebo? So when you're going to get your vaccine, you're getting a vaccine. Clinical trial's done, you're getting your vaccine. But in a trial, you want to know if someone gets salt water or the vaccine, does it prevent them from disease? And also you want to know what the side effects are, and does it actually make the antibodies we want it to make? And that's what they found here. They found, and just focus on the pattern of the graph. It separates out, it shows the incidence of infections. The bottom lines for both Pfizer and Moderna are the people that got the vaccine. The top lines are the people that didn't get the vaccine. Quite simply, it separates. You see more infections in those that did not get the vaccine works. There's some subtle points here. I'm highlighting sort of the days it starts to separate. So at about day 14 post dose 1, you can start to see some protection, but the protection is much more, you can see it's a little bit more clear once you get to 2 weeks after your second dose. So that's where those numbers come from. When people ask, so when am I actually protected? 2 weeks after your second dose, we see far less disease. And what we're finding now in real life data, far less infections, and also maybe far less chance that you will spread the virus if you do get infected. So what about side effects? Again, people are required to report this. So they're legally required in a clinical trial to report this. And these were all clinical trial data. Pfizer, Moderna, head-to-head, fairly similar. Some people will get pain around the site of injection. Some people have some redness, swelling. Some even have lymph node swelling. This is not cancerous. It gets swollen and then it goes away. Some people do have whole body reactions that are very similar to the symptoms you'll see with COVID-19. So the fevers, headaches, some chills. It should go away in 2 days. If it's not going away, you probably should get evaluated. And so I know some people that have gotten tested sort of in those first 2 to 3 days. But most people that have these vaccine symptoms have them resolve in a few days. So these were clinical trial data. The CDC has done a great job in sort of focusing on real life data, having people, now that we have millions of people vaccinated, clinical trial, 70,000, now we have millions. Can we get a better sense about the side effects? And they're fairly similar to the clinical trial. So the box that's highlighted is just showing kind of a scattered pattern of pain, fatigue, headaches across all vaccines. We've been giving Pfizer for longer, so we have more data from Pfizer. And just highlighting here what has happened in dose 2, you can see that increase when you compare dose 1 to dose 2, more people reporting fatigue, headaches, fevers, and chills. It's not surprising. So your body has seen the spike protein, sort of prepped itself with dose 1, and then dose 2 is to boost that preparation. So when you have those symptoms, it somewhat suggests that your body clearly is trying to, is using the protection it created and is sort of increasing it. So this is a good thing. It's particularly important because we're seeing variants circulating. So we want that boost to make as much protection as we need. There are other ways that vaccine safety is being monitored. So are the vaccines safe for those with allergies? That's another question that comes up quite commonly. Even prior to COVID, there are systems in place to monitor vaccine adverse effects. And I just pulled some of the data that the CDC has summarized from the initial 2 weeks of vaccination. They have case reports of some vaccine reactions, and that injection there is just showing sort of the breakup point. But these are just raw numbers. So 2 million doses in December 2020. There were 21 true cases of anaphylaxis where you would have had to use an EpiPen. There were 86 cases of something that may have been an allergy, but it's not quite clear what it was. And then 61 cases of people just reporting things, but definitely not allergies. So millions of doses, small numbers in terms of anaphylaxis and some allergic reactions. Since December, they've given even more doses, and this just came out last week. The bigger question has been, so if I do have allergies, am I at risk for a severe allergic reaction? And so looking at people that, so over 9.9, so 9 million doses of Pfizer and 7 million doses of Moderna. Again, in terms of anaphylaxis, a severe allergic reaction that you need to use an EpiPen, we're seeing less than 100 cases for both individually, 47 for Pfizer, 19 for Moderna. I'm not underplaying that vaccine reactions do happen. It's just such a rare event. I don't expect it to happen in a large amount of people. When it does happen, this is just a summary of people that had severe reactions. Age range from 24 to 63. It's neither here nor there, sort of cut across all adult ages. They seem to be predominantly female. So Pfizer reported 94%, Moderna had 100% female. Not sure what that is. We know that sometimes females do tend to have more allergies, and maybe that's what this reflects. Symptoms tended to occur early, so it was within 10 minutes, and everyone that's getting vaccinated is monitored for at least 15 minutes. And if you have a history of allergies, which seems to be an important point here for those that do have reactions, they're monitored for 30 minutes just to make sure they don't have an immediate reaction. And then the last point I just wanted to highlight, I've spent all this time talking about vaccines. We know they work. We know they, most people it's safe, and it certainly doesn't. Most people don't have allergic reactions. Some do. And now we have all these variants to worry about. We've seen the numbers. This was from a few days ago. We are seeing, so B117, that first row, is the one that spread fast in UK. B1351, it's the one that spread fast in South Africa, and P1 is from Brazil. Slowly increasing in terms of number of states reporting, and North Carolina has joined. We have seen the UK variant. We've also seen I think it was the Brazilian, based on what NCDHS has said. So is this concerning? Are the vaccines still going to work? So I think I would just go back to what the viruses do. And I saw this description, which I really liked. So think of it as sort of the virus is winning the lottery. If the virus replicates, so if it buys one lottery ticket, if it only gets spread to one person, there are far less chances of winning if you have one lottery ticket. But if you have multiple lottery tickets, you just increase your chance of replicating, of winning the lottery. So with each mutation, the virus either tries to evade our cells or evade the vaccine, or just survive longer. The more we do to prevent viral spread, the fewer lottery tickets the virus has, and the fewer chances mutations would occur. So it kind of circles back to us and what we're doing and how we're preventing this. I do want to state that the recently described variants, they have many mutations, and there are concerns that they stick to our cells a bit better, so they change their spikes and can attach a bit better, which could lead to worse spread. And they could start to evade our tests. So we make tests based on the spike protein, and if they change it enough, then we may miss it. And we don't want to see people that are positive having a negative test and sort of going around to spread. But the reassuring thing is only a few tests right now that the virus has mutated against. For the most part, most of our tests still pick them up. And while it may impact clinical disease and death rates, some of the variants we haven't seen, I think the UK data is sort of still coming out, but we haven't seen a ton of death associated with the variants yet. Masking, distancing, cleaning will work. This virus is just in a small fatty layer that you can easily wipe off, even the variants. And some of the vaccines should work, but time will tell. The vaccines that were tested in South Africa definitely had lower efficacy, but at the population level, it probably gives us a little bit of protection, but maybe just not as high as compared to the type of virus or the strain that was circulating last year. So those are the sort of general slides I had. I will stop sharing and either pause for questions now, or we can address them later.
Dr. Akinboyo, there is a question that came up in the chat, and that question is there anything that we can do and or eat to make a spike protein in our bodies?
So not in theory, no. The only way we can sort of generate that response is by exposure to the spike protein, which is really by exposure to the virus. And I would not necessarily advocate for that as a strategy. So getting infected to get the protection is probably not the best strategy, because we know, as we heard, getting that infection can be pretty significant. And again, the protection you get from your regional infection may not last or protect against all of the other variants. And so that's why the vaccine at least allows us to generate that protective antibody against multiple different types of coronaviruses.
Okay. Are there any other questions from anyone else? How about alternative preventive therapies? I know that did come up at one point.
So therapies to prevent against getting infected. Is that what the question was?
Yes.
It's funny, I just had this conversation with a family member who was asking me about some supplements. And they've studied things like zinc, vitamin C, some of the over-the-counter supplements, and in a lab or based on the data that's been published, there hasn't been a very specific supplement that can counteract COVID-19, but making sure you're taking whatever supplement it is, fruits, vegetables, to maintain your immune system is likely advised, because if you have a functioning immune system, to an extent, you can better protect yourself. But I still will go back to exposure. I would rather we focus on not getting exposed at all, and mounting our defenses using the vaccine as compared to getting exposed to mount our defenses. But there is no strong scientific evidence to suggest that you have to take something. If you're taking things to boost your immune system, you should probably continue. That shouldn't hurt.
Okay, there are questions coming in on the chat. So these are the questions that I'll be asking now. How long are we protected once we get the vaccine?
We are trying to figure that out. I say we as general, we in medicine, we expect, the data I've seen suggests that at the very least, we should expect 12, maybe 18 months of protection. If we're not seeing cases spread in our community, we may not even need boosters. So for example, look at Australia, New Zealand. They're not seeing a ton of cases and they're sort of going about their merry life, and they have not vaccinated their entire population. So we may not need boosters, similarly to we don't get boosters for smallpox vaccine because we don't see it in our community. But for now, we expect protection for about 12 or 18 months, and potentially, I think some companies have discussed boosters in about 2 years or in a year. I don't know that as well.
So are we to understand what you're saying is that we won't need to get this annually like the flu shot?
It's possible. It's a little too early to tell. I think the reason I'm hesitating is because of the newer variants. It just described one in California. A lot of companies are saying, at the very least, we may need one more shot next year just to account for all the variants we may be exposed to in the United States.
Okay. One person asked, says that this individual gets side effects very easily from medications. And is this individual at a higher risk for a reaction from the vaccine?
So if that means you have allergic reactions to medications, you are not at a higher risk for side effects. You could have allergic reactions. So two separate things. All of us could get side effects. So pain, I got my 2 doses. My first dose was fine. I barely noticed that I got it except for some pain in my arms. My second dose, I certainly needed a day off. I felt every aspect of that list there. It was a bit rough, but it wasn't an allergic reaction. It was just a side effect. Mm-hmm. So if you have a history of allergies, please ensure you discuss with your provider. The only contraindication is if you have an allergy to polyethylene glycol. It's such a specific allergy. If you have it, you would know. If you do, the vaccine is contraindicated, but everybody else can likely get it, but you may just need to be monitored for 30 minutes, or you may need a Benadryl or something. So talk to your provider in that context.
All right, there's a couple more questions and then we're going to move on. Do you have an opinion about the Johnson & Johnson vaccine?
I do. The problem we're getting with some of these companies is we're seeing data as press releases, which is a bit concerning. I think it would be helpful to see the entirety of the data and sort of say, this is what they saw, this is how it works, these are the groups where we think Johnson & Johnson should work. From what I've read, and they will have this, by the way, they will release all that data. They're just waiting for their meeting with the FDA, which is next week. But from what I've read, so it's a slightly different technology. I didn't address that today in my talk. It uses a vector, so it almost has a messenger that takes the spike protein instruction into your body. It's an inactivated virus, which has scared a few people. It's called adenovirus. So now you're dealing with another virus, but it doesn't cause infections in humans. It's just sort of the messenger that carries it in. And then it does all the same things. So it tells your body, make the spike protein, and your body creates protective elements. When they tested their vaccine, they tested it in Latin America, and I think they were more international than some of Pfizer, Moderna. So their numbers are slightly lower, but that may just mean they were testing their vaccine while variants were spreading, which actually is good. So we know how it works against variants. I haven't seen all of their data, so once we see that, it would be helpful. I guess my opinion is I need to learn more. When it's approved or when it's authorized, it's likely safe and effective, although that measurement or that percent you may see is probably going to be slightly, it's definitely lower. They've already released that, so it's lower than Pfizer, Moderna. But if it's offered, I would take it as well.
Okay, thank you so much, Dr. Akinboyo. Now I want to introduce the panelist. We have, of course, Dr. Ibukun Christine Akinboyo, the Assistant Professor of Pediatrics, Infectious Diseases, Duke University School of Medicine. And we also have the Reverend Dr. Paul Murphy, who is the lead pastor of Trinity Amazon Church and a member of the HEAL Partnership. We also have the Reverend Dr. T. Anthony Spearman, who is the president of the North Carolina NAACP and a member of the HEAL Partnership with Duke. And we have Dr. Michelle Laws, who is the Assistant Director for Consumer Policy. Thank you for the pictures. And Community Engagement, North Carolina Department of Health and Human Services. I am on the left, and of course, we just heard Dr. Akinboyo, and that's Dr. Spearman there in the center, and then Dr. Laws, and of course, Dr. Murphy there on the right. And we're so happy to have them as our panelists for this evening. And we have some panel discussion questions, and this is an open discussion for them. Each panelist will have the opportunity to address each question based on their own areas of expertise, experiences, and policies at their respective churches. So the first question is, and attendees, you please continue to submit your questions in the chat, okay? So as the panelists address these questions, you may have some questions that you want to ask as well. But the first question is this, dealing with the vaccine access and distribution. What is the plan to ensure that the COVID-19 or the SARS-CoV-19 is accessible to our communities, local and statewide, Duke, health systems, health departments, and organizations, trying to make that very inclusive. What is the plan there? And we have, the panelists can answer that. And so whoever wants to begin.
So,
Okay, go ahead.
oh, go ahead.
No, please go ahead. I am no Duke
Okay.
spokesperson, but I can try.
So I'll go from the perspective of the state. And when I say the state, I'm representing the North Carolina Department of Health and Human Services. Mm-hmm. So early on, we knew that we observed the data and we discovered and knew that access to vaccines and those who were getting in line to get vaccinated, we observed some very glaring disparate effects and impacts and outcomes as it relates to our, what we call our historically marginalized populations. So, for example, when we first distributed the first doses and the second doses back, December 14th through January 25th, the data showed that of those persons who received their first vaccine, 82% were white and 11% were African American, and 3% were Hispanic, and 1% were represented among our American Indian populations, and 3% Asian populations. In terms of the second dose, and when we rolled out the vaccines and made them available, 80% of whites had received their second dose, and 9% of African Americans, and then right at a little at 4% of Hispanic and Latinx populations. The most recent data that we've looked at, 14.7% of African Americans received the first dose, have received their first dose, and about 10%, 11% of African Americans have received their second dose. 78% of white, 82% the second dose, 78 the first dose. 2.4% of Hispanic of the first doses, all the doses administered up to this period, actually up to the February the 13th, received 2.4% of the Hispanic population have received their first dose, and 2.46% have received their second dose, right? So we knew quickly that we needed to implement and operationalize vaccine equity in our rollout, as well as what we were, the guidance that we were given to our distributors, which are the local health departments, hospitals, and then of course you've got two pharmacy players, which are Walgreens and CVS. And so in our equity strategy now, that wasn't it on the front end. We didn't roll it out. We, you know, some of us were predicting that we'd see the kind of disparate outcomes, but it wasn't on the front end. But now our vaccine equity strategy includes making sure that we have this overarching or metric where vaccine rates have to reflect or exceed the population estimates of African Americans or Blacks, Hispanic or Latinx, American Indians at the county and regional as well as the state level. And so what we do is we allocate baseline weekly amounts of vaccines based on the county populations to ensure that we're getting geographic equity with the vaccines distributed and that are available in all 100 counties. We're providing an increase in allocation to counties. We call it the equity bump in counties with higher numbers of low income adults, ages 65 and older, which is where we are now in our distribution priority scale or schema, and higher numbers of historically marginalized populations that are 65 and older. So low income, as well as representatives of our historically marginalized population. So income plus, so we've got an SES or indicator or metric, which is low income. And then we've also got a race and ethnicity metric, and those combined. So over 30,000 doses have specifically been allocated to communities with people that are 65 and older living in high poverty areas or with high representation of HMPs. We are also outlining clear expectations for vaccine providers when they accept the weekly allocation, that the percentage of vaccine administered to historically marginalized populations and minority populations in high poverty areas should meet or exceed the population estimates in those communities. And then we're directing allocations specifically to providers that serve those communities that I just mentioned with that formula, and partnering also with community-based organizations, our HBCUs, and faith-based organizations that have reached into those communities that have been underserved and that we are continuing to observe. We're closing the disparity gap, but that we continue to observe where there's disparity. So it's a multi-pronged approach that the state is employing, and I'll leave it there and allow others time to answer. But there's more that we're doing, and certainly as looking at next week, February 24th, when we are moving to group 3 in our priority eligibility classes or groups. We're moving to group 3, which are frontline essential workers, but we're starting out with people working in childcare and pre-K through 12 schools. And then on March 10th, we're planning to roll in the additional frontline workers. But we still recognize that we still have a large segment of the populations in two in particular who have not been vaccinated, that again meets those two criteria: high poverty or poverty areas, and also that are represented among our HMPs.
All right. Thank you. Anyone else want to add to, well, anyone else who wants to address this question, I should say?
Yeah, I should, my caveat is that I am not the official Duke spokesperson on this, but I sit on a vaccine equity committee and I can share some of the work around this. Similar to what Dr. Law said, we certainly could do better in general about vaccine equity and distribution. I think quite often nearly everyone that's involved in the process sort of waits until we start distributing, we see the data, and then we react, versus preemptively saying, we know what's happened before. It's happened with testing, it's happened with every single thing that has rolled out, until we can predetermine where certain things should go. I don't make all these rules, but I appreciate the fact that there have been some changes to allocation, which has allowed for some flexibility in distribution. And so what I mean by that, of course, as you all know, early allocation went directly to clinics and hospitals for healthcare workers. And as we broadened to include 75 first and then 65, we immediately realized that our process for having people book an appointment skews to a certain group, because if you have to be online and click something or refresh something or be on a phone for hours, you could easily lose a group of people. And I saw someone in the chat mentioned people that are disabled, people that don't speak English. They're just a number of groups that we easily lost in that first rollout. And so it took a little while, but there's been a lot of work in ensuring that transportation is provided, ensuring that we're going through the wait list and moving through that as quickly as we can, setting up community sites. So two occurred this past week. I personally was at Nehemiah Christian Center in downtown Durham, providing vaccines. And so having sites that are not necessarily based in a clinic or in the hospital, which means everyone has to kind of come to the hospital versus just going out to where people are. And recently, I know Duke is working with Meals on Wheels for people that are already receiving meals and seeing if we can, you have to kind of time these things right. They're only stable for 6 hours at room temperature. So you have to defrost, plan who's getting it, get it out there, vaccinate, and get back for the next one. So it takes some logistical planning, but we've done great things over the past year, and we're certainly capable of doing this. So there has been a more intentional focus on equity in distribution processes to remove obstacles in terms of access, and certainly in the groups. So like moving through 65 as quickly as we can. And I will share some of the, it's publicly available as to the distribution of people that have been vaccinated, but with the intentional focus in the last 2 weeks, the proportions have nearly doubled in just 1% of Black and Hispanic people that are now vaccinated.
And may I add, I forgot two important pieces of our strategy as well. So utilizing community health workers has really been a game changer in our strategy, not just get people vaccinated, but also testing, to increase testing, which we still need to be doing, and also working through the historically marginalized populations work group that includes both DHHS internal folk as well as external representatives. And we've got some amazing partners, Dr. Viviana Bianchi Martinez at Duke, who gives us just extraordinarily amount of support and guidance in terms of working with not only the Latinx and Hispanic populations, but also African-American populations that make up a large part of her patients, the patients that she serves. And so utilizing community health workers, getting them on the ground to help organize and engage and get people to sites, and especially community sites, and also always thinking about how we can do it better and processing that thinking through a structured format, which is our historically marginalized population work group that meets weekly.
Certainly the North Carolina NAACP, which I consider to be my church these days, and we span the length and breadth of the state of North Carolina. For the most part, we have branches in each and every county across the state. If there's not an adult branch, there's a youth and college chapter, college division chapter. And certainly we, as an advocacy group, we're doing all that we can to get the right messaging to our people, not only the African-American community, but as Dr. Laws said, the Latinx and the indigenous communities as well. And so as such, we do our yeoman's best to connect ourselves with local judicatories and local municipalities, county commissioners and such like, and have the churches passing on to them the persons who are identified as the populations that are eligible to receive the vaccines to these individuals, so that they can roll it out to the public health departments, Cone Health here in Greensboro, and make sure that everybody who is eligible to get the vaccine can get the vaccine. Of course, it becomes a challenge because we're also dealing with folk on a continuum. I mean, we have folk out at the end of the scale that say, we want the vaccine, no doubt about it. And then we have those at the other end that are skeptical about the vaccine. And so education, teaching has to be factored in to assist these individuals to gain or to become more encouraged to get the vaccine, and we hope that they will by the end of the day. So we also have been working in concert, or doing our best to work with the Department of Health and Human Services, as Dr. Laws well knows, by connecting our branch presidents with the Department of Health and Human Services, so that they can serve as intermediaries to assist in rolling out and getting the numbers up in the minority communities. Because we've been on calls, we're on calls almost weekly, and we have seen the disparate numbers of African Americans being vaccinated over and against Caucasian Americans being vaccinated. And certainly each week we stress over that, but it seems to be growing. So the work is going forward, the work is being done. I personally have been vaccinated. I had a scare in the beginning where there were about 10,000 of us here in the city of Greensboro whose scheduled appointments were canceled because there was not the allotment of the vaccine that was rolled out to the city. So, and of course, I was fearful for a while. Having started, let me just say this, having started on the end of the spectrum that said, well, maybe, just maybe I can make it without it. But thanks be to God, I have my youngest child is a medical doctor, and he was on his mother and I like white on rice that we were going to do it without a shadow of a doubt. And so we kind of got up under his jurisdiction and said, okay, well, we are going to do it. He, as a matter of fact, he's the father of our youngest grandchild, who is now 15 months old. And certainly we want to see her again. So we said, if that's the common denominator, then we most certainly want to do that. So we're going to get the vaccine. I have received my first vaccination. My second is due on the 25th of February. My wife got her second yesterday. Was fearful, Dr. Akinboyo, that she was going to have some severe reactions, but to date, she's doing okay, and we're grateful for that. So I'm going to do just as she did, and take some Tylenol or whatever it was she took when she went to get her second vaccination, and take some myself, and just confirm that I'm going to be all right. So we're trying to do everything that we can to work in concert with whoever we can to make sure that we get the numbers up in our respective communities.
All right, we're going to prepare to transition to the second question, but there is one question just prior to us doing that, that someone raised about those persons who may be homebound, who are sick or disabled and cannot get out. And I heard someone mention, may have been Dr. Laws or Dr. Akinboyo, talk about transportation, but what if they're not mobile? I'm not sure. How do we get them vaccinated?
So I had two options. I think there are our relationship with community workers who may be tapped into some of this, some people that they already need help and they're already helping with some of the aspects of life, may be the best way to get vaccines there. So I mentioned Meals on Wheels, and that's for homebound. It's just targeting people that meet the age criteria, but are also homebound. And then the next has really been figuring out, at least so far, as far as I know, it's figuring out ways to still facilitate moving them to a site, which I know is probably not the best plan. We need to come up with more creative plans. I also know that some of our other institutions are using mobile vaccines clinics, similar to mobile testing, where they just go, you have to plan ahead. Again, the vaccine is only stable for so long. So it is a short list. And they just go around and provide the vaccine and then head back to the hospital and refill and do it all over again. So small numbers, but people are trying. And while I have the floor, Dr. Spearman did remind me about something. Because I was talking about side effects, I may have overemphasized side effects. Note that there are a ton of people that got vaccinated and nothing happened. They did just fine and they barely even noticed. So you certainly don't have to take Tylenol. You may be just fine. You can wait until symptoms actually develop to take anything. A lot of people are fine.
And if I could,
I want to add to the homebound and the disabled. And so in addition, I think the mobile units we know are, miracle responses to a lot of communities, especially in our rural areas outside of Durham, outside of the RTP. When you get outside of the RTP, it's a very different world that people are trying to navigate through in terms of getting access to health. So in addition to, looking at and exploring, partnering with organizations that have mobile units to provide vaccinations, just like we use them for testing, also utilizing our EMTs. And we work very closely with the National Guard and other agencies that have been critical in our responses to natural disasters. So getting to people who are, trapped in a flood zone, getting to people. And so we at the state are looking at some of those resources that we've deployed during natural disasters and seeing whether or not they would be appropriate to use also in this instance to reach people who are not mobile. And then of course, there's funding that is available to provide free transportation via public transit bus services that people can access through, contact your local DSS to find out, but that's for mobile people. But I also wanted to put that on the table. And then the last thing about the side effects, and Dr. Akinboyo can slap my hand on this. We were on another panel together, she and I. But I tell people, if your arm is hurting at the injection site, if you're feeling a little feverish, that's not a bad sign. That's a sign that your body is doing what it's supposed to be doing, and that's fighting off what it perceives to be an infection, a virus, or something that's not supposed to be happening, right? So that's what you want. You want your body to build up antibodies. You want your body to respond. So I tell my family members, if you're calling me to say, hey, help, can you contact somebody? My arm is sore. Give it a few days, because that's probably just a sign that your body is responding the way it's supposed to.
Reverend Murphy.
Yes, I was just going to share that the churches definitely in place. In particular, our church leadership in the Zion Church, they're planning various usages of facilities that we have on site to be places where vaccines can be administered, and we having the feeding programs and the outreach programs where we are working with the sick and the shut in. Those might create some opportunities as well to reach those people possibly with those mobile units. But some of the interesting challenges that I'm finding, though, from the ministerial point of view, has a whole lot to do with what Dr. Spearman shared about getting the right messaging and the right information out, because we have so much of the social media that's flooded with, the conspiracy theories, things that really should not even matter, but because of the emphasis and the impact that these formats have on the minds of people, they fall into these categories. So it's important that in our teaching and our preaching and just in working in ministry, that we give people the lens through which to witness the miracle that God is creating amongst us. And so that's our contribution.
Thank you. Excuse me. Thank you all so much for your contribution to question one. Now we'll move on to question two. And when we look at this, why should we continue to wear masks? Should we continue to wear masks after vaccination? Let us also take a look at any initiatives. Let us look at any strategies that we may have in place or are considering putting in place to continue to actually, going back to messaging, to help our people to continue to stay masked in our communities. So anyone can jump in on that right now.
I can start it off, but I'm curious to, particularly about messaging around this, I'm curious to the rest of the people on the panel to see if they would like to add some things. So the graphs that I showed vaccine works, placebo doesn't work as we expected. As you saw, the line for the vaccines was not exactly zero. There were a couple of people that still got infected after vaccination. And this is not shocking. That happens with every vaccine. So think back to 2 years ago. It seems like forever ago. We're all discussing measles and Disneyland and all of the travel. Most of us were vaccinated or had measles back in the day, but most people were vaccinated against measles. And we still saw spread, because when you bring an infection back into a community, even though you're mostly protected, if everybody is not protected, so if you don't have 100% protection, you can see spread. We're talking about sort of the slow vaccine rollout. Hopefully we'll get there. We'll get to a point where most people are vaccinated. So in the meantime, it's still a low line, right? So it wasn't a lot of people that were getting infected, but some people can still get infected. The good thing is, even if they get infected, if they're vaccinated, we're seeing some early data that suggests they don't spread as well. And that could help us at the population level. But I'll prefer that you don't get infected and you're not amongst that small number that could get infected. So currently, while we're still seeing spread, we're still seeing thousands of cases in our local communities, it's more important that you stay masked in areas where you could potentially get infected, grocery store, for example, or crowded areas or outside your household, until further notice. But things will change. Things will absolutely change. Things are already changing. For example, if you're exposed and already vaccinated 2 weeks after your second dose, you don't have to quarantine per the recent CDC guidance, particularly for work. So in the healthcare setting, we've adjusted that to allow some freedom around how we cope with quarantine. And this would also impact somewhere like school, where you may not have to quarantine a whole bunch of teachers if they're vaccinated. So there's some trickle-down effects. Things are already going to change, but for the short term, we do have to stay masked until we see more people vaccinated or 0 cases, whichever one comes first.
Okay. Murphy?
Yeah, I found it interesting. My youngest son brought up something that he noticed here in the local area. He said, Dad, when the first word got out about masks that they would protect an individual from catching the virus, everyone had masks on. But he said about a week later, when it was mentioned that, well, the masks don't guarantee that you can't catch it, but it can prevent the spreading, then suddenly there emerged this anti-mask movement. I want my rights. I don't want my rights violated, and no one can make me wear that mask thing, which he says it sounds like they just want the statistical folk that they're hearing to die, they want them to die. That was a loaded statement. So I'll just say that.
Okay.
My philosophy with the mask is simple. I once heard it said that it's better to have it and not need it than to need it and not have it. And so that's the way that I govern myself. I have generally been going into the office on a daily basis and have 2 people that I work around there. And when I've noticed that when I enter the building or enter the office with my mask on, and usually when I enter, one of the people that are there working with me doesn't necessarily have hers on, but when she sees me with mine on, she'll put hers on. And so I think modeling before them the way that I would like for them to, again, the messaging is the way to go. And since taken the vaccine on the 4th of February, I've actually double masked up. I wear my N95 and I wear my mask on top of it. So I'm taking every precaution necessary, because those who I come into contact with don't necessarily know that I've been vaccinated.
And Reverend Spearman makes a good point. The point that I wanted to make, to just add to all of the other wonderful responses to that question, is a lot of the spread was through asymptomatic people who weren't showing any symptoms, who didn't know they had it. And so that's one reason why we need to continue to wear the mask covering our nose and our mouth. And also, the vaccine is just another piece of armor to help us. It's not 100% going to protect us 100%, right? So, both Moderna and Pfizer, 95% effectiveness. And then, if Johnson & Johnson comes online to market, I think it was 70% or something to that effect. And so, one, you don't know, and you can't look at someone and tell they have COVID. And then the other thing that I heard that, we don't use the fear factor at DHHS. All of our messaging has really been centered around education and giving people, information to help them make good, informed decisions about their health and about preventive measures. But I was on another panel discussion, and someone said it's simple for them. They much rather wear a mask covering their nose and mouth than to be connected to a ventilator. And for HMPs, historically marginalized populations that are still more likely to die disproportionately, that's the reality that we're facing. It's better to wear a mask than to risk getting sick, and also to risk the long haul effects of COVID. We heard I saw on the news the story about the child, the mother who was, really afraid because her child ended up with this systemic systems infection, and Dr. Akinboyo can talk about that. But there are long-term effects of COVID. It's not a get it and it clears up and you are going to be fine. That very well may be the case, and it's probably the case for many people, or for most people. But we also know that there are what we call long haulers. And unfortunately, this pandemic hit populations that were already shouldering a disproportionate burden of chronic health, disease, and illness. And so we can't afford to have African Americans or Blacks, Hispanic and Latinx, and our indigenous populations or American Indians, this vulnerable without encouraging them to everyone to use that very simple protective measure. When we think about diabetes, hypertension, renal disease, late stage renal disease, people who are on dialysis and so forth, in many instances, disproportionately, you're talking about also this same population. And so there are multiple reasons, and I'll stop at just those.
I wanted to just quickly echo that last comment. The virus, as I showed, is very simple. The virus doesn't know your race, your ethnicity, how old you are. What matters has been sort of all of the structural inequities, all of the other comorbidities that have existed and have worsened sort of the impact of this virus on our communities. And I think that's really the take-home point here, where something has to stop and this has to end. And it's not going to be one thing that's going to fix it. It's sort of an additive effect, and the vaccine is sort of that extra step there to help us get out of this. We still need to fix a whole bunch of other things that have been going on for years. And that's COVID sort of exacerbated some things. But for now, we need to sort of get rid of this immediate problem as we continue to fix other things.
And for the ministers, I am one ordained in the Baptist Church. Union Baptist is my church home. So I want to give a shout out to my pastor, Prince Rainey Rivers. Grew up in the United Holy Church. And so, I grew up in the church. And what is so important is that we make sure that one, our people are not perishing for lack of knowledge, that we're listening to the facts from doctors like Dr. Akinboyo and others, that we are making sure that we're doing our part to share information, and that science and religion go together, right? Albert Einstein recognized that point. And so one doesn't cancel the other one out. And so I think messaging is extremely important. And so when Reverend Spearman said that that's one critical role that the NAACP has been playing, it certainly has, is sort of debunking some of the myths, countering some of the false information. And then the other point I'll make, again, we recognize, and I know Robert Merton's theory of cumulative advantage and disadvantage really has been studied and applied in other settings and looking at other issues and topics. But we've seen it play out here. Those who've had more have had a cumulative advantage. They were the ones who could get in the car and drive to another county to get vaccinated. But if you don't have public transportation, if you're out in the county and don't have public transportation, or if you're working hours that don't allow you to go in during a 9 to 5, when health departments might be open or whatever. So we are seeing this Matthew effect, is what Robert Merton would say, right? Those who have more get more. So we are seeing some cumulative advantage and cumulative disadvantage. And that's the reality of it. And so also at DHHS, we are looking at ways to address some of the cumulative disadvantages that play out in the form of health disparities and health inequities.
All right, I do want to remind everyone of an event that's taking place at Southern, used to be called Southern High School, also known as Southern School of Energy and Sustainability, 800 Clayton Road. It's in the chat. with the African American COVID Task Force, AACT, plus we'll collaborate with Duke Health to host a vaccination clinic on this Saturday from 8:00 a.m. until 5:00 p.m. Also, along with that, we have there's another town hall next Tuesday hosted by the African American COVID-19 Task Force, AACT. So keep that in mind as well. So I would like for any final comments from any of our panelists because we're about ready to close. This has been a tremendous opportunity for us to be able to get together and to share information with each other. So are there any final comments from the panelists? None? Okay.
I do just want to say to Dr. Murphy, I really appreciate your sharing your testimony. Very touching. And the closest I came was my daughter, my oldest child, was confirmed with the virus. And of course, we were tremendously frightened because she is also a lupus sufferer. And so she spent 8 days in the hospital, and each day, and that was in Michigan, and each day my wife and I were tremendously frightened by what might be her plight. But thank God she survived and she's doing well. So thank you for sharing that. Thank you.
And Dr. Laws shared her contact information by email in the chat. And keep in mind that this has been recorded and it will be shared with anyone. Davon put the link information in the chat as well, but if you will contact Kanisha Bethay or Davon Williams, they will be glad to give you, I believe it will be a link, but don't hold me to that, to this presentation. So I want to thank the panelists again. I want to thank the attendees. The panelists are certainly experts and leaders in their fields, and they have provided much for us. I want to thank the attendees for coming as well. And if you were watching the chat, you notice that we had someone make some comments, but then I think just kind of dropped off. But that is what it is. Now we have some poll questions, some final poll questions. You did a pre-survey. Now this is a post-survey, and we've lost some as well. We had around 48 or so, now we're down to 36. So, but for those of you who remain, if you will be so kind to answer just a few questions for us. Number one, if you have not had the vaccine, how likely are you to take the vaccine if available? And this is based upon the discussions and the presentations we've had this evening. Number two, how likely are you to encourage your family and friends to take the vaccine? Okay, I think we should move on to the next. Ready for 3 and 4?
Hey, Dr. Dowdy, those are the only questions on this particular post survey. So 3 was the last question.
3? I see 2. You say 3?
Yes, the third question says, if you are not taking the vaccine, please share why.
I don't see that.
Yeah, you have to scroll down.
Ah, I see.
Yeah.
Okay, cool. All right. Well, as soon as everyone has submitted, we shall take a look at the results. Wow, see the results there. Very likely, 36%. NA, 36%. Maybe you've already taken it, not sure. How likely you'd encourage your family and friends to take the vaccine? 64%. Not sure who the attendees are, not sure your backgrounds, but yeah, that's really good. Likely 14%, NA 21%. Fear 7%. The pre-survey, we did not have anyone to list fear by C. Now we have fear as 7% and allergy 7%. Those are the only ones that, well, 93% is other. Curious what the other is so high. The people are not taking it. But anyway, those are our results. And I want us to be able to share this with you all. The process, Davon or Kenesha, can you help us out with the process of getting this back to everyone?
Yes, so for those of you who have emailed us directly, we will definitely make sure that you receive the link. And then Davon and myself will pull together a summary of tonight's discussion. And we will send that summary out with the link to this recording through some of the similar channels that we use to promote this event. And that way we should be able to hit all of the communities who are interested in receiving the recording. Thank you to our amazing panelists, and of course to you as well, Dr. Dowdy. I will pass it back to you.
All right, well, thank you so much. You all are very kind to me, and I just ask you to continue to pray for me. And it's 8:02, and you all have been very attentive and very faithful, but now we're gonna cut you loose where you can do what you do. Shake a leg, eat something, drink something, or get ready for a midnight slumber. Or whatever floats your boat. But thank you so much. God bless you. Godspeed.
Good night.
Good night.